Hey, you guys, I'm just going to give people a little bit of time to get loaded in and then we'll get started. Hey guys, I'm just letting a few more people in, some stragglers that are going to join us today. So we'll get started in a few minutes. Hey, everybody. I'm just giving a few minutes for a few other people to get joined in, and then we will get started. Thank you for joining me today on this Wednesday afternoon. We'll get started in just a few minutes. All right. Hey, guys. I'm Dr. Haverland. I think it's about time to get started. There may be a few other stragglers that are joining in, and so I'll let them in as they come. Um, I'm Dr. Rachael Haverland with Endometriosis Center of Excellence. Thank you for joining me on this webinar today. Today, we're going to talk about endometriosis staging and the impact on symptoms and fertility. I think this is a very important topic just because of the stage and how it's kind of been amplified to be such a determining factor, but when really a lot of times stage means almost nothing. And so I think it's really important to walk through this webinar together, understand the impacts of stage and how it affects fertility, but also how it can affect your pain and how your pain is perceived. Um, this is an interaction. I would like this to be interactional, so please feel free to comment, post onto the chat. I would love to have some feedback from you guys. If there's something we talk about this doesn't make sense, or something that is a little bit difficult to understand, please let me know. I want this to be kind of back and forth. I want to make sure that I get to some of your questions at the end. I also want to make sure that this is educational. This is my passion. This is what I love talking about. I could talk about endometriosis for hours, and I realize I can get a little long-winded, but I do want to stop occasionally and talk to you guys about some of the findings or questions that you have that may not be making sense as I'm kind of discussing. Um, someone mentioned in the chat and asked if this is going to be recorded or emailed. I'm working on getting my YouTube channel set up, and so hopefully we'll be able to upload this there, and so you'll be able to watch it, or at least tidbits of it with different. Under some different topics, but hopefully it'll be available for viewing after we get off of the webinar. Okay, so let's go ahead and get started. Again, as other people come in, I'll make sure to invite them and they can get caught up. So today we're going to talk about endometriosis staging and the impact on symptoms versus fertility. So the one thing that we're going to talk about in this webinar is why the stage of your endometriosis means almost nothing and what really predicts your pain and your fertility future. This is the most important thing. Why stage of endo means almost nothing and what really is going to predict your outcomes. So women are told their stage determines everything: pain, fertility chances, even their future. But staging was never designed to predict outcomes. It's outdated, it's misleading, and it leaves women confused. dismissed, misdiagnosed. This webinar reveals the truth, why staging doesn't explain your pain, while fertility can't be judged only by your stage, and the hidden tool that gives more accurate answers. And I think this is very, very important. By the end of this session, you'll understand while stage 1 can still mean brutal pain, while stage 4 sometimes reveals no pain at all, while staging does very little to predict fertility, but especially pain scales, and different tools that you can use to evaluate fertility, including the Endometriosis Fertility Index, your HSG, your AMH, and other tools that you can use to evaluate what your fertility looks like. So you were told your endometriosis was mild. So why were you doubling over in bed, missing work, terrified about the future? Meanwhile, women with stage 4 are conceiving naturally, and it doesn't add up, and you deserve to know why. Endometriosis does not always follow the rules, and that is why it's such a difficult disease to predict and to anticipate. But I hope that after this webinar over the next hour or so, you'll be able to have a little bit better understanding of how endometriosis stage can predict some outcomes, but why there's many areas that are still very gray. So all of this is explained without fear-mongering or false promises, just the truth. So you can finally stop guessing, stop Googling, and start planning with confidence. So I am Dr. Rachael Haverland. I'm an endometriosis excision specialist here located in the Dallas area. I am with the Endometriosis Center of Excellence, where we use a multidisciplinary approach to treat endometriosis. Endometriosis is very much of a whole body disease. It affects your, the inflammation of your body as a whole. It can affect your metabolism. It can affect your diet. We try to treat it that way with a multidisciplinary, holistic approach to endometriosis, ultimately, which also includes the gold standard of endometriosis excision surgery. It's very important to note that some of my patients are fertility patients. In fact, probably half of my patients are referred to me for fertility purposes specifically. The other half of my patients are here for pelvic pain. Sometimes they do desire fertility in the future. However, I have many patients that really don't. Fertility is not something that they've ever desired or something they've wanted in their lifetime. And I want to make sure that I address that. Women are much more than just baby makers. We have a lot to offer in this world. So I'm going to talk about a decent amount of fertility and how it corresponds to endometriosis today, but I want to make sure that I'm also clarifying that my job as a surgeon and as an endometriosis expert is not just to focus on the fertility aspect, where it can be very important and very beneficial. There's lots of aspects of how endometriosis can affect women. So kind of getting back to our webinar again. I want this to be interactive, so if you have any questions or comments, please feel free to put them in the chat. I will be checking it sporadically to be able to interact with you and talk to you throughout this next hour, explaining about stage and its correlation with pain and fertility. But as you do have questions that come up, please put them in the chat. I would love to try to be able to answer some of those individually. And like I mentioned before, hopefully this will be placed on my YouTube channel if I can figure out the IT to get it going. But I'm working on it. So hopefully in the next few days we'll get that going. So what if I told you that your stage of endometriosis has almost nothing to do with how much pain you feel? And it has some correlation of if you can get pregnant. So research shows women with stage 1 endometriosis can also struggle to conceive, while women with stage 4 endometriosis can get pregnant naturally. And it's not an absolute, but it's definitely something to consider. The stage is only a label. It does not tell your story. There are so many different aspects of endometriosis in the fertility world. So I'm Dr. Rachael Haverland. I'm a board certified GYN surgeon specializing in endometriosis and reproductive health. I've seen hundreds of women missed by staging, dismissed by providers, and really left hopeless about fertility. My mission is to expose what staging really means and what you should be looking at instead. So by the end, you'll understand how staging actually works, and while it kind of fails women in many ways, the overlooked tools that predict fertility better than staging, and how to use this knowledge to take control of your journey, whether it's fertility, whether it's pain, using this information. Knowledge is power. The more knowledge we have about our disease, about our history, about our options, the better chances we have to have a better outcome and long-term success. So if you stay to the end, I'll give you my fertility planning checklist for endometriosis to kind of talk you through the different options of what we're looking for when we're looking at fertility, and this roadmap that I use with my patients to maximize their time and their options. And so first we're going to talk about, the lie of staging, right? There's a misconception that higher stage means worse pain. That is absolutely not true. And I think this is the biggest misconception of endometriosis. I have a lot of women with early stage disease, rather stage 1 or stage 2, that are just in debilitating pain. They have bowel symptoms, they have bladder symptoms, they have pain with intercourse, they have, vomiting with their pain because it is so severe that they cannot function. And we find endometriosis, and sometimes they don't feel that their pain is validated, but it absolutely is. Your pain does not correlate to your stage. And I think women in general can be gaslighted from that. Like, oh, well, you just have stage 1 endometriosis, so your pain doesn't correlate to what you're experiencing. And that's not true. Endometriosis is a chronic inflammatory disease. It affects your nerves, it affects your muscles, it affects the central sensitization of pain, it affects your mood. It is very real. This disease doesn't discriminate. It doesn't matter if you're stage 1 or you're stage 4. It can wreak havoc on your body and cause pain. So if there's anything I want you to get out of this webinar, is that stage does not correlate to symptoms. Women with stage 1 endometriosis can have debilitating, excruciatingly terrible days and flares, whereas some women with stage 4 technically really are mostly asymptomatic. Maybe they just have trouble getting pregnant, but stage does not correlate to symptoms. And if you have stage 1 or stage 2 disease, your symptoms are valid. They are very real. They are still likely related to your endometriosis, and they deserve to be treated and taken seriously. So staging is based, just to talk a little bit about staging. So staging is what's seen at time of surgery and what pathology confirms. So as an endometriosis excision surgery, when I go in, I literally look at everything. I leave no stone unturned. I look at every organ in the abdomen and pelvis that I can evaluate. I look at the diaphragm, the liver, the gallbladder, the spleen, the stomach, the small intestines. I look at the pericardium. I look at the appendix. I look at the colon. Down in the pelvis, I'm looking at your ligaments. I'm looking at your nerves, the blood supply. I am dissecting the peritoneum. I'm looking at your fallopian tubes, your ovaries. I look inside the bladder. I look at the rectum, the colon, the sigmoid colon. I'm evaluating all of these aspects of the abdomen and pelvis that I can see. I'm a little type A. I want to make sure that it's done correctly and it's done right. Just do it once and do it right. That is my motto. And so stage is based on what I see at time of surgery and what pathology confirms. And so it is very important to always take specimens and send them to pathology so that they can confirm endometriosis. Tell me which areas have active endometriosis. They look at cells and endometriosis glands and stroma. They have to see both of these components in order to call it endometriosis. The pathologists are very strict on this definition, which I actually think is important. My pathologists are very good because they also do some explaining, like, hey, they met some components of this, the glands, but they didn't have the stroma, or they have some hemosiderin staining, which is likely only related to endometriosis, but I want them to be precise in their diagnosis. And I think that's really important for outcomes, but also just for mapping, like where the endometriosis was, where your symptoms are they related? Is this referred pain? Is this pain that's actually in the area where you're having pain? Or endometriosis exactly in the area that you're having pain. So I think it's really important to map that out. So if you do not have pathology from your endometriosis surgery, or you only have 1 or 2 areas of pathology, you likely did not have an excision surgery. When I do endometriosis excision surgery, I take minimum 7 specimens, and that's on like an early stage endometriosis, or if I don't see anything like obvious, I still take at least 7 specimens to make sure that we're not missing any microscopic disease, because sometimes you don't even see the endometriosis until you start to dissect these areas, and if you don't look, you will miss it. And so Stage is correlated, or stage is based on what we see at time of surgery and what pathology confirms. So this is not always correlate to your fertility. Endometriosis is the most common cause of unexplained infertility. If you don't look for endometriosis and evaluate for endometriosis, it's not unexplained because it's almost always endometriosis. So the next steps is what do you want to do about it? But excising endometriosis and removing the endometriosis has shown proven benefit both with natural conception and through IVF by improving the environment and the quality of the pelvis so that you have better outcomes. So this classification is not a crystal ball. And sometimes patients after surgery, they ask me what stage they are. And I don't always want to tell them because I want them to know that their pain is real. If they don't have stage 4 disease, if you have stage 1, stage 2, even stage 3 disease, your pain is real. The symptoms you're experiencing is real. It is still from the endometriosis. But I always want them, I always discuss this with them, if not beforehand, especially afterwards. Your pain is very real. This is related to the endometriosis. Stage does not always correlate to symptoms. So I had a patient, a young patient. She was like 21. She could not get out of bed for weeks at a time. Weeks at a time. I mean, she barely had a few good days out of the month that she was able to function. She was missing school. She wasn't able to go to work. She was missing social functions. This was affecting her mental health. She literally was in fetal position a lot of times in the bathroom, just waiting for the pain and the flare to pass. When we did her surgery, she had stage 1 disease, and I talked to her about it. She was a little bit disappointed after surgery. And there's actually benefits of having stage 1 disease. If we excise endometriosis when it's early stage, the risk of recurrence is a lot lower. The risk that her symptoms or the chances that her symptoms improve are much better. And so there's actually the goal with endometriosis treatment is to try to treat it at an early to moderate stage before it gets too advanced. Because when it is more advanced, stage 4 disease, you have a much higher risk of recurrence. It can affect fertility more readily, and I'm going to talk about that a little bit later. I had another patient with stage 3 disease. She barely felt pain, but she couldn't conceive. Her pain was very mild, but they saw an endometrioma on her imaging when they were going through her fertility workup. And so they're able to say that, her endometriosis is likely the problem behind her inability to conceive. But she was confused. She was like, I've never had painful periods. As we started talking through some of the symptoms, she had some very mild symptoms that may correlate, but it was mostly benign. Her quality of life at this point had not been affected. And so endometriosis stage does not correlate to symptomatology. And I think that's very important. If anybody gets anything out of this hour today, the most important thing is that stage does not correlate to symptoms. So staging is very much of an outdated map. You cannot navigate your life with it because it is not black and white as to how it is going to affect you going forward. Next, okay, I'm going to go over to a few questions and then I'll pop over to going back to the webinar. Let's see. Can you see the lungs or heart from that area? So when I do surgery, I mentioned that I look at everything. The first thing that I look at is the diaphragm and the pericardium. So the heart is beating. I can see the pericardium move. I can see the diaphragm move with breaths. However, you have to go into the pericardium or into the diaphragm past the muscular layer to get to actually see the heart or to see the lung or get into the thoracic cavity. And so if I see endometriosis on these areas, I excise them, and then we excise them to see how deep that they are. If they are deep going into the pericardium, then I have my cardiothoracic surgeon come in. If we're deep going into the thoracic cavity, then that's where I have my cardiothoracic surgeon come in and help me evaluate to make sure that we get all of the disease. This is less common, but it's certainly not impossible. Probably a few times a year we're having to get into the thoracic cavity, but 90% of the time when endometriosis is on the diaphragm, we can just shave it off the diaphragm and we're getting good margins. There's healthy tissue behind it. It's not growing all the way into the thoracic cavity, but it certainly can happen. One more thing to note is you guys will see a link on this chat. So this link is to schedule a time to meet with my my office coordinator. Her name is Cyrus. She will help go through your insurance. She'll go through the dates that are available for scheduling to see me as a new patient. So what I want to clarify is that when you click on this link for the calendar, this is not a meeting with me directly. This is a meeting with Cyrus. She's my office manager. She will help you get scheduled with me. So if you click on this link, schedule a time where Cyrus will call you at a scheduled time, and she will get you ultimately scheduled with me. But I want to make sure that that's clear. So when you click on the calendar, it is not a visit with me specifically. It is a visit with my office manager, and she will help get you scheduled with a visit to see me. But she'll talk you through kind of the scheduling aspects and sort of talk you through what that looks like. All right, so now the next thing I want to talk about is the fertility predictor that doctors are rarely using, or especially in well-known society. Most endometriosis specialists understand that there's a lot more that goes into the fertility aspect. So staging predicts there's a misconception. Staging predicts whether or not I will get pregnant. And I think that is a very, very difficult topic. So fertility and pregnancy, there are so many aspects that go into this. Just going over some of the most important aspects. So staging, the more advanced stage of endometriosis that you have can mean more of an uphill battle for fertility. So lower stage, while it still certainly can affect fertility, once it's excised, has much better chances of not recurring. Less damage has been done to the ovaries and the fallopian tubes, so your chances of natural conception or through IVF go up quite a bit significantly. Women with stage 4 disease, they have more damage to their other organs. The ovaries have been affected. Usually the fallopian tubes have been affected. So even with extensive excision surgery, the likelihood that you can get pregnant naturally is a little bit lower than, say, somebody with stage 1. However, it is not impossible. I actually got a lovely letter from a patient this week who I hadn't seen. I did surgery for her back in 2023, and she sent me a card and a beautiful picture of her newborn son, and described how, she had advanced endometriosis, and after excision she was able to get pregnant naturally. And at that point she was sort of planning to go the IVF route and talk to the fertility doctors, but she was able to get pregnant. And the reason is it's ultimately we are optimizing the environment of the pelvis. And so we're optimizing the environment of the pelvis. You have better quality eggs. The egg and the sperm are more readily able to meet in the fallopian tube, and then also implantation into the uterus. So excising and removing the endometriosis by improving the environment of the pelvis gives better chances and optimizes your chances of fertility, both with natural conception and through IVF. With that being said, stage can correlate to how it affects your fertility. More advanced stage of endometriosis may affect your fertility more than early stage endometriosis. However, they all have an effect. Even early stage endometriosis certainly can affect fertility because of this same negative inflammatory environment. So fertility outcomes are influenced by many, many things: age, ovarian reserve, surgical findings, not just stage, but surgical findings, how your tubes are affected, how your ovaries are affected. There's also something called the Endometriosis Fertility Index. It combines these into like a little bit better predictor. And so this is a tool that some of the fertility doctors use, where you can put in, how the tubes are affected by endometriosis. Were they dilated? Are they open? Where's the endometriosis on them? Do you have history of an endometrioma? So endometrioma is a cyst on the ovary that's filled with endometriosis. These cysts are very caustic and very irritating. They affect the eggs that are made on that side, on that ovary with the endometrioma. Women with a large endometrioma, those eggs on that side tend to be poor quality than an ovary without an endometrioma, or maybe on the other side that maybe doesn't have an endometrioma. Removing an endometrioma also decreases your ovarian reserve to some degree. And I think it's very important. I always talk to my patients, about this. What does removing an endometrioma do to your fertility chances? It can lower your AMH. The bigger the endometrioma, potentially the more effect it will have on your ovarian reserve. Women with endometriosis already at baseline have more damage to their ovaries and may have a lower ovarian reserve. And so it's really important to talk about this. Now, after removing the endometrioma, they may have higher quality eggs on that side. Their fertility doctor may be able to access the eggs on that side, because with the large endometrioma, you can't go through the endometrioma to get to the eggs when you're doing an egg retrieval, because it's caustic and very irritating. So it damages the eggs that you collect. So depending on where the endometrioma is located, sometimes fertility doctors aren't even able to access that side. And so it's a very important discussion to have, but it's a benefit and risk discussion to understand exactly what's happening to your body and how surgery will benefit your chances of fertility, but also some of the side effects that they may have on some of your labs and your ovarian reserve. So I mentioned this earlier, but I had a stage 4 patient in 2023, and she was told her chances of natural conception are essentially zero. She came to me and we started talking about, her AMH, her age. From what they could see, her HSG had shown that her fallopian tubes were open at this point. They weren't dilated. And staging, she was told that she had advanced stage 4 endometriosis, and staging essentially like just destroyed her hope. At this point, she was only planning to go through IVF and talk, but she wanted to talk to me about surgery. And we talked about how with the endometrioma, it may lower her AMH, but excising the endometriosis may improve the environment of the pelvis and therefore give her better chances. She had talked to doctors, and she actually has embryos that she was planning to transfer after we did the endometriosis surgery. So we did the surgery. It was very extensive. She had endometriomas on both ovaries. However, one thing that was to her benefit is the tubes had not been affected yet by endometriosis. The tubes were open, they were not dilated, there was not endometriosis on the tubes specifically. We did an operative hysteroscopy, which means we look inside the uterus, make sure there's not any polyps, fibroids. It's a happy place for an embryo to implant. We also did a CD138 staining, which tests for endometritis. After all the endometriosis was removed, the cysts were removed, the ovaries were reconstructed, we did flush her tubes and make sure the tubes are nice and open. She was able to conceive 4 months later, and she'd been trying for almost 5 years before that. And this is truly amazing. And the difficult part about this is not every patient will be this way. Not every patient that has endometriosis surgery will be able to get pregnant naturally. There's patients that do not have endometriosis surgery that are able to get pregnant naturally. But statistically, with removing the endometriosis, excising the endometriosis, removing the disease, you have better outcomes for the next 6 months is what the statistics show. So your future is not defined by your stage, the Endometriosis Fertility Index, your age, your AMH. Of course, you need the sperm, you need healthy sperm, and the ability of your tubes to be open are the most important factors in evaluating for your chances of success with future pregnancy, both before endometriosis excision surgery and afterwards. And sometimes it's hard to anticipate how much endometriosis will be present in the pelvis when we go in for surgery. We use imaging to try to give us our best estimate, but it's not perfect. And so it is an important discussion to have after surgery. What does this look like? Where do I stand? What does my fertility look like? What are my chances of being able to get pregnant naturally? How do my tubes look? Did the inside of my uterus look okay? Is it a happy place for an embryo to implant? What are the ovaries? What are the volume of the ovaries? Were there big endometriomas on the ovary? What was my starting AMH? What is my, AMH after surgery? And so these are all very, very important questions. And it's very individualized. Again, this is not a one size fits all. So stage can correlate to fertility, and because of the damage that it does to the pelvis and to the other organs, but especially the fallopian tubes and the ovaries. Endometriosis, causes this inflammation and can cause some irreparable damage to some degree. But to But to clarify, stage is not the only factor on your chances of successful conception. There's a lot more factors that play into it, and I think it's very important to review these together because some women have stage 4 disease, but like I mentioned, their tubes are not yet affected, or maybe they only had an endometrioma on one side. Maybe kind of depending on what type of endometriosis or where the endometriosis is, and after surgery, what your outcomes are very much individualized, just depending on what we find at time of surgery, how all the findings are, and your other characters that can help anticipate what your chances of natural conception are, or your conception through fertility. All right, so I'm going to go to a few more questions over here, and then I'll pop back over to the webinar. This patient asked, to be able to find out if you have endometriosis, do you have to have surgery? And that's one of the most difficult parts about endometriosis, is that we don't always know. And a lot of times we cannot see concrete evidence on imaging. You have, quote, normal ultrasounds and normal MRIs, but we know it's not normal. What you're experiencing is not normal. I actually have a shirt that I wear sometimes to endometriosis conferences that says, "This is not in your head. It is in your pelvis." Like, your symptoms are very real. And it is true. Technically, to diagnose endometriosis, you have to have surgery and have pathology to prove that you have endometriosis. However, you can have a very high suspicion based on symptoms and based on your history. People with a family history have a much higher likelihood. Now, if you have advanced stage endometriosis with a large endometrioma, or they can see endometriosis on imaging, that is confirmation. Unfortunately, at that point, your endometriosis is more advanced. With an endometrioma, you're at least stage 3, potentially stage 4, depending on what you find. So if you wait until you can see it on imaging, it's very much of an uphill battle, because your chances of complete, or your risk of recurrence after a stage 4 endometriosis are much higher than if we can catch it at an earlier or moderate amount of endometriosis. All right. I have one more thing that I want to talk about. Is a positive receptiva test, but no signs or symptoms of endometrioma, enough reason to believe endo is the reason for fertility? Absolutely. Endometriosis is the most common cause of, quote, unexplained infertility. The receptiva test, while not perfect, does have a high positive predictive value. I see it all the time. I see many women who are desiring fertility, rather going through fertility treatments or wanting to conceive naturally, come see me with positive receptiva tests. And we talk about it. We go through all the symptoms. Sometimes you have symptoms you didn't really even know were related to endometriosis, and sometimes you don't. I have plenty of women who are mostly asymptomatic, and we go in for surgery to clean out and improve the environment of the pelvis, and they do have endometriosis. A receptiva test is a reasonable, less invasive test to evaluate for endometriosis. We don't have a lot of tools in our toolkit to evaluate for that. Again, it's not perfect. Surgery is the gold standard to test and to treat endometriosis, but I also realize it is invasive. And so the receptiva test is a reasonable test. But yes, absolutely. With unexplained infertility and a positive receptiva test, that is your answer until proven otherwise. All right. So the next thing I want to talk about is there's this misconception that my stage dictates my treatment plan. Treatment is not a one-size-fits-all, and I think we've touched on this a little bit. 2 women with stage 2 endometriosis could have totally different paths depending on fertility goals, their age, their ovarian reserve. Endometriosis treatment plan is not a one-size-fits-all. Now, the things that I do classically recommend for almost all of my patients is this multidisciplinary approach of diet, exercise, acupuncture, pelvic floor physical therapy. Those are kind of my base. I always recommend that to almost every patient. But going forward, their treatment plans are not always the same. Do they desire fertility? Do they also have concomitant adenomyosis? Have they taken medications in the past, like birth control or progesterones? Are they trying to wean off of those, or are they wanting to start them because of the adenomyosis or inflammation of the uterus? Are they working with a fertility doctor? What are their next steps? Do they have embryos that are already banked? Are they planning to go through an egg retrieval going forward? Are they planning to do a transfer? Have they talked to their doctor about potential suppression before their their embryo transfer? I mean, these are all very, very important questions, and I deal with this every day. And it's important to understand each patient's goals and their desires, but it is not a one size fits all. Patients deserve this individualized, high quality and evidence-based approach. And many times it's not offered, or it's more of an algorithm. But women with endometriosis do not fit that algorithm. Endo does not follow the rules. And so there's not an algorithm that fits patients with endometriosis, because it's very individualized. The stage doesn't correlate to pain. Women have different goals in different areas in their life. Maybe they've already completed childbearing, or maybe that is their ultimate goal, but they're getting towards the end of their fertility window. It's important to listen to your patients and understand what their goals and their needs are going forward. And that is how you create a plan that is going to be most beneficial to everyone, both myself and the patient, and their future goals and outcomes. So, one of these things where this is not a one size fits all. I had one stage 2 patient that pursued surgery and then was able to conceive naturally. Another chose egg freezing and IVF. She banked her embryos. Then we had surgery, and then she went forward with her transfer and was successful. But they were both able to be successful in their journeys. But it's everyone's path is different. It also depends on if their tubes were affected. If your tubes are damaged, even with fimbrioplasty, which I do perform as long as there's enough normal ovarian tissue or normal fallopian tube tissue to save, your chances of conceiving naturally are going to be a lot lower. The tubes, you have to have at least one functioning tube to be able to get to conceive naturally. And so it's important to sort of understand those goals. Or is your AMH declining? Do you have really low ovarian reserve? That's very common with endometriosis. Some women with endometriosis see their AMH decline even earlier than you would think that they would on average compared to their peers of the same age. And so it is very important to understand your body and have this full evaluation. And also when discussing surgery, discussing some of the positive outcomes, but also the potential downsides of removing an endometrioma, for example, and your ovarian reserve and your AMH, and how that may affect you long term. So aligning treatment with your aligning treatment with your personal fertility goals gives you control. Staging alone takes that control away. And so that's why it is so important to understand each individual, what their goals are, and then that helps you kind of guide for next steps. But again, endometriosis patients do not fit an algorithm. Endometriosis does not follow the rules. Every person gets an individualized, high quality and evidence-based treatment plan. And that's ultimately what you deserve. That's what endometriosis patients deserve. Because some patients, their ultimate goal is fertility. And I have some patients that's not their goal. They've never wanted to be, have genetic children of their own. They just want their pain to be improved. And so it's important to understand that for each patient, and then help them achieve their goals in whatever way that is. So I'm going to go back to the chat and see if I can answer some more questions, and then we'll kind of go back to the staging, the fertility, and the pain aspect. Let's see. Oh, one more thing I wanted to mention again. We've had a few other people join. So in the chat, you will see a link. This link is to schedule with my front desk, my front office manager. Her name is Cyrus. So this link will give you a time to meet with her. At this time, she will call you. You'll be able to go over scheduling, sort of what that looks like, if you want to come in person or if you want to do a telehealth. But this link is not to schedule an appointment directly with me. This link is to schedule with Cyrus, my office manager, and she will ultimately get you scheduled with me. But at that time, she will call you. She'll get your insurance. She'll go over scheduling, and then ultimately find a time to get you scheduled with me. But I want to make sure that that's clear. This link is to schedule a visit with her, not with me directly. We have to get a little bit more information from me before we can get you into our clinic. You can also schedule a visit by calling the office or submitting a form online. Both of those are good ways. All right. So can someone have thoracic endometriosis and not have any symptoms? I guess that's possible. I would anticipate you to have at least some symptoms of endometriosis in general, maybe not thoracic disease. Women with endometriosis, especially more stage 4, it's very common to have endometriosis on the diaphragm and going into the lung cavity. But if you're completely asymptomatic, like no painful periods, no fertility, no GI symptoms, no bowel symptoms, no bladder symptoms. I don't see a reason why you should just go looking into the lung, because that, that is certainly an invasive procedure if you're completely asymptomatic from anything. But if you have endometriosis symptoms or you have endometriosis elsewhere in the body, it's certainly possible that you can have thoracic endometriosis. That's relatively common. Um, Someone said, I read an article that mentioned how getting pregnant can, quote, cure endo. Have you seen a case before? This is an old wives' tale. This is kind of a patriarchal myth, which is very frustrating for me. I actually see this even from some of my colleagues telling young women, "Oh, just get pregnant and your endometriosis will go away." That there's no evidence that that is the case. Your endometriosis does not go away on its own. Sometimes it goes away after menopause, but technically endometriosis can make its own estrogen. It can use other hormones it has aromatase properties where it has properties where it can use other hormones and transition them to estrogen. But getting pregnant does not, quote, cure endometriosis. Your endometriosis will still be there. In fact, it will continue to stay the same or grow with time. But there's no medical way that we have to make endometriosis completely resolve itself, including pregnancy. Now, some women in pregnancy feel better because their progesterone is high. When you have high progesterone, theoretically, it may help suppress the endometriosis, but it doesn't make it go away. And if you truly have endometriosis, once you come out of pregnancy and your estrogen and progesterone go back to baseline, your symptoms typically recur within the first few months. Now, not all women with endometriosis see this benefit of high progesterone and improved symptoms. There's some women with endometriosis that continue to be symptomatic throughout their pregnancy, which is very disappointing. But yeah, I always tell people this is not a guarantee that you will feel better during pregnancy. Now, the good news about endometriosis and pregnancy is endometriosis tends to affect the act of getting pregnant, but once the placenta starts to grow and you reach that 8, 9, 10-week mark, you're no longer considered high risk. So you can have early miscarriage, more common with endometriosis. However, once you get out of that late first trimester, you're no longer considered a high-risk pregnancy, which is at least for endometriosis specific. There's many other ways that you can be considered high risk, but that's the good news. All right, let's see if I can answer any other question. What size is considered large for an endometrioma? I think that depends on your symptoms and sort of how you're asking. Any endometrioma, any endometrioma size can be very caustic and irritating to that ovary. Any size of endometrioma can affect the egg quality on that side. The larger the endometrioma, the higher risk that it may damage your AMH, but I've seen endometriomas 13, 15 centimeters. Most of the ones that I operate on are closer to 5 to 7 centimeters. But the goal is to try to catch them and treat them as soon as you find them, because it tends to do less damage to the ovary when you're removing a smaller endometrioma compared to a very large endometrioma. But any endometrioma is damaging to the ovary. Any endometrioma, of course, can cause, significant pain. Like I mentioned before, endometrioma already puts you at stage 3 disease. So you're already at a more advanced stage disease. And if you see it on imaging with this endometrioma, it's never just on the ovary. Never. I've never had a case where I go in and the only area of endometriosis is on the ovary, because we have stage 3 disease. It is traveled. It's on your nerves. It's on your ligaments. It's around the bowel. It's around the bladder. There's a lot of different areas where endometriosis has affected. But the only area that you can see on ultrasound or MRI imaging is the ovary. And so it's important when you see this to try to treat it as quickly as you can, not necessarily like emergently, but within the next few months to make sure that it's not continuing to grow and worsen, which ultimately can cause more damage to your ovary. Let's see. If you've had a laparoscopy done years ago, is it bad to have a second surgery? It depends on what was found at the time of surgery and if they did excision surgery. So excision surgery, where they go in and they're excising and removing all the tissue, you feel like they did a thorough job. They looked at all of your different organ systems, the nerves, the bowel, the bladder, and you had a true excision surgery. Subsequent excision surgeries tend to give less and less benefit as far as pain. And so it depends on what was done at the first surgery and also what was found. With stage 4 or more advanced endometriosis, you have a much higher risk of recurrence. If you have an endometrioma or a cyst on your ovary, it'd be reasonable to go back in for an additional surgery to try to help preserve that ovary, to try to help preserve the functionality of that ovary and the hormones. So it kind of depends on what the findings are of your original surgery, who performed your original surgery, what was done at that time. Because if they just did ablation or they burned the endometriosis, the likelihood of it coming back is almost 100% because it wasn't completely treated at the beginning. Um, and Let's see. Okay, so again, I wanted to mention that there is a link in our chat. Click on that link if you'd like to. I would love to meet with you in person and talk individually about your personal endometriosis journey and some of your goals. Talk about if you've had surgery before, how you were staged, if fertility is your goal, what are the other kind of data points that we have to help give you kind of an estimate of what this looks like or what your chances of natural conception are versus, needing to work with a fertility doctor and some more invasive options but everybody's journey is different. So use this link here. This link, again, is not a direct visit with me. This link will give you a visit with Cyrus, my office manager, and she'll go over kind of our scheduling and how the scheduling works, and she'll get you on the books to see me rather in person or a telehealth visit. So, after this, webinar, you kind of understand why staging is so limited, why there's other factors relating to fertility that may be more important, like the Endometriosis Fertility Index, your age, your AMH, if your fallopian tubes are open, and how treatment planning, really works, but is very much individualized. But the problem with this is even with this knowledge, it can feel overwhelming to figure out your next steps. And so the goal that I have in my office is to turn this into a personalized fertility plan. What are your goals? What are next steps? How do we help you meet your goals with the information that we have? So we open a limited amount of consultations a month, usually about 10 consultations a month, to ensure that we have personalized attention. Once they're gone, we have 10 consultations the next month. Right now, we're booking out about 10 weeks. But if you want clarity about your fertility future, don't wait. I'm here to talk to you about your history, your future, what this looks like, where if endometriosis excision surgery is a good plan for you, what that looks like, implementing the other multidisciplinary approaches to help improve the environment of the pelvis. But it is important to understand that this is individualized. So stage does not correlate to symptoms. Let me just preach that to the choir. Stage does not correlate to symptoms. Women with stage 1 endometriosis, your symptoms are valid. They are real. Women with stage 4 endometriosis, it can have a higher risk of affecting fertility. The higher stage of endometriosis you have, the higher risk that you have that it will negatively affect your fertility, but it's not absolute. And you can see this happen all of the time, both with natural conception and through IVF. And so I want to help you on your journey. I have a few more questions here on the chat. So, does stage predict if I'll need IVF? That does not. Stage does not the only predictor of if you will need IVF. There's a lot more that goes into that. And I mentioned that earlier. You have to have good functioning tubes in order to conceive naturally or through IUI. Your tubes have to be essentially perfect. I can help open them. I can help flush dye through them. Sometimes you do something called a fimbrioplasty to help make the tubes better. But if you do not have functional tubes, that is a big predictor of if you will need to go through IVF in order to conceive. If you have functional tubes and your AMH is appropriate and you're ovulating regularly, you don't have PCOS or things like that, your chances of natural conception are a lot better. And so it really is very much individualized, but it's not a stage correlates to need for IVF. That is absolutely not true. Another question on the chat, can I conceive naturally with stage 3 or stage 4? Absolutely. I see it all the time. After surgery, if you have more moderate to advanced stage, I usually recommend starting to try pretty immediately after surgery. We flushed your tubes. We've looked inside the uterus to make sure it's a happy place for an embryo to implant. Everything is optimized at this point. Your endometriosis is not going to recur that quickly, so you have better chances of success. So I have patients start trying, pretty regularly after surgery, timing their ovulation and trying around that. If you go more than 6 to 9 months after surgery and you haven't been successful, at that point, at least have you talk to a fertility doctor to kind of discuss some of your options and review the plan and make sure we're not missing anything, because I don't want to waste your time, especially if that's something that's very important to you. Um, I have this last one that says, what if I have severe pain, but I have low stage? As I mentioned this before, stage does not correlate to symptoms. Your stage 1 disease absolutely is affecting your pain and a contributor to the pain that you're having. Endometriosis causes systemic inflammation. It can affect your bowels. It can affect your bladder. It can affect your metabolism. It causes fatigue. Low stage of endometriosis actually absolutely can cause debilitating pain, and your symptoms and your disease are valid, just as valid as somebody that has stage 4 disease. And so don't let anyone gaslight you or tell you that this is not accurate, because it's absolutely not true. So kind of to close this webinar, this is your chance to finally move past the confusion and get a clear plan for your fertility and your ultimate goals, even if fertility is not your goal. Don't wait. Book your consultation with me. I would love to meet with you and talk to you about your individualized goals, your pain, your symptoms, your history, what that looks like, and how we can make a plan together. So again, this link is in the chat. You can click it when you make a scheduled appointment. This will be with Cyrus, my office manager, and she'll be able to get you, talk to you about scheduling, and then you'll get on the books with me. So just to make sure, this link is not a direct visit with me. This is a visit with Cyrus. She will call you at that assigned time and then ultimately get you scheduled into our clinic, rather in person or telehealth visit. But I look forward to meeting with you. I hope you learned a little bit about endometriosis and how it affects stage, and how fertility has so many more factors that go into it other than just stage of endometriosis. And also how pain very much is validated with endometriosis. Even low stage can still affect fertility. And I think it's just very important to realize that endometriosis is not a one size fits all. Endometriosis does not follow the rule book. Each person deserves individualized, high quality, and evidence-based care. And that's what I want to give to you. But I also want to give a little bit more education, every month, to help women advocate for themselves and learn more about their disease. Thank you guys for meeting with me today. I really enjoyed talking with you. We will see you again next month for our webinar again. Yeah, I'm honored that you came and spent the last hour with me, and I look forward to seeing you in the clinic if I haven't already. Y'all have a good rest of your Wednesday. Bye-bye.